Heart Association's Cardiac Bootcamp series. This is our final webinar in the 7-week series. Before we get started, we would like to go over a couple housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. Attendance of this webinar will earn you 1 CE credit. Instructions to claim your credit will be sent after the webinar. Today's topic is over the cardiac anatomy and physiology, as well as heart attack treatments and procedures by Dr. Steven Siegel. Dr. Siegel was born in Macon, Georgia, and after receiving degrees in chemistry and medicine at Yale, he trained in internal medicine, cardiology, and interventional cardiology at Yale, New Haven Hospital, and Yale University. In 2001, he received a master's degree in medical management from the Naveen Jindal School of Management at UT Dallas. In 2002, he founded Siegel Heart Center in Tyler, Texas, where he practiced until joining the Heart and Vascular Institute at Titus in Mount Pleasant, Texas, in July of 2016. There, he helped design and bring on a new cardiac cath facility, which began doing cardiac interventions in November of 2016 and became a 24/7 STEMI center in September 2017. He has been named to USA Today's list of most influential doctors, and for the past 6 years has been chosen by his peers to the Super Doctors list in Texas Monthly Magazine. And with that being said, I will hand it over to Dr. Siegel.
Thank you very much, and thanks to all of you for attending today, the last in this series of the STEMI Bootcamp sponsored by the American Heart Association. I have no formal disclosures for the talk, but I'd like to start with talking about why we're doing all of this. Despite all of our efforts at reducing death rates and mortality and morbidity from heart attacks, it still remains the #1 killer in our country. And as this map shows, particularly in the area that I work in Northeast Texas and many other areas, the rates are unacceptably high. And these are not just numbers, these are people. These are people that we work with, people that we go to school with, people that are our neighbors and friends, people that we meet in the grocery store and in restaurants. And each of these deserves a chance to have a long and productive life. And it's through your efforts that we're able to try to help them reach that goal. Why do we have such high rates of heart disease? Well, some of us don't eat very well. Some of us don't have very good exercise habits, and some of us have really lousy family histories. But whatever the reason, heart attacks are still occurring, and our goal is to try to give people the best chance at surviving and thriving after their first heart attack. We're going to follow loosely the Get With the Guidelines data entry and go through some areas of anatomy, physiology, and clinical medicine that pertain to these in order to help you understand a little bit better clinically why we do things the way we're doing them. Now, I know that many of you have long clinical backgrounds, and for some of you, this will be a brief review. For others of you who are relatively new to the program and who do not have extensive clinical backgrounds, we'll probably cover a lot of new information today. The guidelines, of course, are summarized in these 2 articles from 2013 and 2014 for the Guidelines of Management ST Segment Elevation MI, and for the Guidelines for Management of Patients with non-ST segment elevation MIs or acute coronary syndromes. And if you've not read these initial guidelines, I encourage you to take the time to read through them because they will explain in much more detail many of the things we're talking about today. Now, to begin, we're going to go back to high school biology a little bit and talk about the way the heart is structured and the way the heart operates. So as you'll remember, the heart has 4 major chambers, and blood returns from the body through the inferior vena cava and the superior vena cava to the right atrium. It goes through the tricuspid valve, enters the right ventricle. The right ventricle then ejects it through the pulmonic valve into the pulmonary arteries, and pulmonary arteries carry the blood to the lungs where they're reoxygenated by passing through the capillary bed. That oxygenated blood then returns to the left atrium through the pulmonary veins. It then flows through the mitral valve into the left ventricle. The left ventricle then contracts and ejects blood through the aortic valve out into the aorta and into the rest of our body, which is how, of course, our body obtains its oxygen and nutrients that it needs for survival. Now, Most heart attacks involve the left ventricle of the heart, the reason being that the left ventricle is a strong muscular chamber which has a lot of myocardial oxygen demands, less so with the right ventricle and with the atria. So by far, when we talk about heart attacks, we're principally talking about damage occurring to the left ventricle of the heart. To a lesser extent, it can occur to the right ventricle. It can also occur in the atria, but that's extremely rare because these are very thin-walled chambers. They don't have a lot of myocardial demands because they're not forced to squeeze against pressure the way the left ventricle is. On this diagram, you'll also see here depicted some of the electrical system of the heart. I tell my patients that the heart you can consider a little bit like a house. This is the structure of the house. This is the electrical system of the house. But how does the heart itself get its nourishment? It gets it through the arteries, which is essentially the plumbing system of our house. If I can get this to advance, there we go. So here is a diagram that shows the plumbing system or the coronary arteries. The left main artery arising from the left coronary cusp of the aortic arch. It then gives rise to the left anterior descending artery, which travels down the front wall of the heart. If we can get to the right slide. And then it also gives rise to the left circumflex artery, which passes behind the heart and going to the lateral and posterior walls of the heart. The right coronary artery arises from the right coronary cusp, moves to the inferior wall of the heart, gives off branches here that go to the right ventricle, and then gives off a large branch here, which in 80% of people will become the posterior descending artery and go down the back wall of the heart, and posterior lateral branches that will go to the side wall of the heart. In about 20% of people, the posterior descending artery will come off the left circumflex artery here. Now, coronary artery disease is not a static thing, it's a continuum, and you can see depicted in this model various stages of coronary artery disease. Here we have a relatively normal artery in cross-section, very smooth lining or endothelium, a small layer of what's called the media, which contains muscular tissue and elastic tissue and collagen, and then the adventitia, which is supportive connective tissue. Early in life, at least in Western societies, we begin to develop some fatty deposits in the wall of the artery, usually here in the media, but it also involves changes in the intima or the endothelial lining, the myocardium as well. As this progresses, you'll have progressive narrowing of the lumen through which the blood can flow. And at some point, you may develop unstable areas like this where you have high degrees of lipid and scar tissue that will bulge and have a very thin fibrous cap over them. This is what we call vulnerable plaque, and these plaques under stress can rupture. And when they rupture and release their contents, they also expose these underlying areas to blood flow. These underlying areas can be thrombogenic, and as a result, the body will form a blood clot there in order to contain the rupture. And as this blood clot grows, it leads to occlusion of the coronary artery, which is the major mechanism by which most people have heart attacks. As this progresses over time, it becomes totally occlusive and eventually will turn to scar tissue if this is not opened, and the artery will be totally occluded with no blood flowing through it. Now, when that happens, the area beyond the artery, beyond the occlusion, will be starved for oxygen and nutrients, and that area will sustain damage, necrosis, and then eventually become scar tissue, and that's what happens when we have a heart attack. So how do we diagnose a patient who's having a heart attack? It's based on symptoms, it's based on physical examination, it's based on their history, it's based on a 12-lead EKG, it's based on their labs, and sometimes based on imaging. As far as symptoms, classic symptoms, chest pain, jaw pain, arm pain, associated with shortness of breath, nausea, vomiting, sometimes just vague fatigue and malaise associated with diaphoresis. And as we know, a lot of times in diabetics or even in women, because their symptoms are not typical, it's the same symptoms most men have, there may be very little of the pain per se, more of the shortness of breath, more of the nausea, more of the vomiting. So the first thing that we are alerted to from a patient having a heart attack are the symptoms they describe. When they come in and they're evaluated, we'll do a physical examination. We'll look for evidence of fluid in the lungs. We'll look for evidence of other causes for the chest pain on their exam, and we'll get a 12-lead EKG. This is a relatively normal EKG here. It shows some minor T-wave inversions in lead 3, but overall it's a normal rhythm, it's a normal axis. There's no evidence of any kind of significant ST segment elevations or depression, so this is a fairly normal EKG here. We'll also draw labs on the patients, and in particular we're looking for what are called cardiac biomarkers. The most commonly used biomarker today is the troponin level. Depending on your institution, it may be known as a variety of different tests, but all of these are ways of assaying troponin, which is a protein that's found in the heart muscle fibers that regulate muscular contraction. As the heart muscle is compromised by an occlusion and causes ischemia, you'll have actual death of the cell in the heart. And as the myocyte dies, it will open and will release some of its contents, including troponin, and we'll be able to detect levels of the troponin in a blood assay. Also, you'll be asked as part of your Get With the Guidelines sheets to measure creatinine levels in patients. The creatinine level is not per se an indication of cardiac damage. It's an indication of kidney function. It becomes important for us in caring for the patient because if we take the patient to the cath lab and we give them a dye load for angiography, that can sometimes affect their kidney. And if the kidney function is poor to begin with, we have a much higher chance of making the kidney function worse with the dye. So the first question when we've decided that a patient is having a heart attack, in terms of triaging how we're going to treat the patient, is this an ST segment elevation MI or is this a non-ST segment elevation MI? By definition, an ST segment elevation MI is going to show evidence of elevation of the ST segments on their EKG in at least 2 contiguous leads in a particular zone of the heart. In this case, a patient is having a large anterolateral ST segment elevation MI. The ST segment elevation means elevation of this area between the QRS complex and the T wave. There's typically elevation of what's called a J point at the end of the QRS complex, followed by an elevation of the ST segment, and there is this classic convex ST segment elevation, which is an indication of ST segment elevation MI. We may sometimes in younger patients see a J-point elevation with a concave elevation of the ST segment, which is a normal variant called early repolarization. And undoubtedly many of you have seen that on patients who come into the emergency room as well. But once we make the diagnosis of a new ST segment elevation or a new left bundle branch block on an EKG, then we have a diagnosis in conjunction with the patient's symptoms and their exam of an ST segment elevation MI. Now, both ST segment and non-ST segment elevation MIs will cause myocardial damage because they are myocardial infarctions. They will have a release of troponin, and they will cause myocardial damage regardless of whether we classify them as an ST segment elevation or a non-ST segment elevation MI. The difference for our purposes in classifying them is to know how to best treat them. And I apologize if these slides are not advancing the way they should, but we'll be there in a second. There's several complications of MIs that you're also going to be asked to track on your Get With the Guidelines forms. Of course, one of the most dangerous ones is cardiac arrest. As we mentioned, the cardiac house has an electrical system, and a cardiac arrest is an electrical problem. This can be either the patient going into an abnormal heart rhythm, such as ventricular fibrillation, or going into asystole and not beating at all. In either case, the heart is no longer pumping in a organized fashion, and there's no perfusion of the body and of the organ systems in the body when that happens. This is when, of course, we perform CPR and try to resuscitate the patient before we do anything else, because if there's no flow to the patient's organs, there's going to be death very soon afterwards. Many of our patients will also have peripheral artery disease. which is the similar type of process that we've seen in the coronary arteries, but in other arteries elsewhere in the body, in the legs, the stomach, the arms, and the head. And that may affect the way that we can treat the patient as well. Many of our patients will have complications of heart failure, either because they had pre-existing heart failure before they came in with their heart attack, or because they had heart failure which came about as a result of myocardial dysfunction and damage. The normal heart, of course, has a very strong muscle and squeezes from all sides and empties the heart forcefully. When a patient develops heart failure, then one or more areas of the heart may not be as forceful. You can see here there's thinning of this anterior wall of the heart, as you might see after a myocardial infarction with damage to the anterior wall. And so as you watch this heart muscle squeeze, this area will not be as forceful. You'll have a decreased function of the heart overall. We measure that by what's called an ejection fraction, which is the percentage of blood that's pumped out by the left ventricle in a single beat. There are a variety of ways to measure this. It can be measured in the cath lab by injecting dye directly into the left ventricle and looking at how well it pumps. It can be measured in the echocardiography lab by looking at changes in the left ventricle between systole and diastole, or it can be looked at in the nuclear lab by injecting a patient's radiolabeled red cells back into the patient and looking at how well the heart muscle can beat during a single beat. Based on that, we can judge that an ejection fraction is normal when it's in the 50 to 70% range, it's moderately decreased in the 40 to 49% range, or it's low in the less than 40% range. When the ejection fraction falls below the 30 to 35% range, we generally then talk about severe LV dysfunction and possibility down the road for adding a defibrillator to the patient because of the high risk of subsequent arrhythmias if there's no recovery in function. Cardiogenic shock is another sequela that can happen from an acute myocardial infarction, and it's a complex multi-system problem. But the basic underlying issue is that the heart has become weakened or damaged to the point that it can no longer successfully perfuse the body's organs. The patient will have a low blood pressure. They may have diaphoresis, cold, clammy skin. Their urine output will be decreased because they're having inadequate blood flow to the kidneys. They may become confused or dizzy because they're having inadequate blood flow to their head. So this is a major life-threatening issue and has to be addressed as well. So as far as STEMIs go, we have the options of mechanical reperfusion or pharmacologic reperfusion. And the guidelines suggest that when a patient presents with the possibility of reperfusion in a goal of first medical contact to device time of less than 90 minutes, then it is preferable to do that mechanically. And so primary PCI is the recommended method of reperfusion in patients who present with a STEMI with onset of symptoms within the prior 12 hours. If a patient presents to a facility that does not have capabilities for mechanical reperfusion with PCI, then it's recommended that that patient be transferred to such a facility if it can be done with the goal of achieving reperfusion in 90 minutes or less. How do we perform mechanical reperfusion? Well, we do it initially with a heart catheterization, which can be approached either from the femoral or the radial approach in most institutions. It involves numbing up an area over the artery, placing a needle in the artery, passing long catheters, long tubes called catheters, up into the aorta, into the aortic arch, placing the tip of the catheter at the beginning of the coronary arteries, injecting dye into the arteries, and taking x-rays while we inject the dye to localize where the blockage may be. So, for example, if in this patient, we find that the patient has only mild blockages, 20 to 40%, which are not going to be flow limiting and not going to require intervention. Again, this patient has a little more moderate disease, around 50% narrowing, and again, not enough to affect blood flow and therefore not requiring intervention. However, here we see a patient who has a blockage, in this case in a bypass graft, that's about 80%, which is enough to be limiting flow and may need to be treated. But more commonly in a STEMI, what we're going to find is 100% blockage, as in this right coronary artery, and it's incumbent on us to try to reestablish flow through this blockage so that we can restore flow to the myocardium beyond the blockage. So we do that then by passing a small wire into the artery past the level of the blockage. Over that wire, we can pass a smaller catheter, which has a balloon on the end of it, and once that balloon is placed across the blockage, we can inflate the balloon in order to open up the blockage. After that, we often will use a second balloon that has a metal stent crimped on it, place that across the channel that we've opened up in the artery, inflate the balloon, and embed the stent inside the artery to act as an internal scaffolding there. We then can remove the balloon safely, and the artery will be propped open by the stent. Now, there's certain reasons why we may have to delay this. As we've talked about, people may have cardiac arrest or cardiogenic shock and need to be stabilized before they can be taken to the lab. They may have difficult vascular access because of the presence of peripheral vascular disease. There may be delays in getting consent from a patient or a family who sometimes can't always decide that they want to proceed. And once we get to the cath lab, we may find that they have complex anatomy and it may be difficult to actually get across the culprit lesion. These are things that are unavoidable delays, and they are taken account by the guidelines and by your data sheets. But they are non-system reasons for delay as opposed to systematic reasons for delay within your institution, which of course we're trying to eliminate. The time course of your intervention is important because it influences outcomes. You can see here that when we have an occluded artery that causes an ischemic zone in the heart, if that is opened within 15 minutes, there's very little damage to the heart. At 40 minutes, there's areas of necrosis that develop, and these will become scar tissue. At 3 hours, the scar tissue will grow to a larger extent, and at greater than 6 hours, almost all of this myocardium will become scarred. And so the faster that we can open the artery and reestablish flow, the more likely we can prevent permanent damage, necrosis, and scarring to the heart. Now, sometimes we know that we won't be able to successfully get a patient to the cath lab and open a vessel within 90 minutes. For example, the patient presents to a hospital which is not capable of doing PCI on an urgent basis. And so in those cases, if the patient can be transferred to a PCI-capable hospital with a goal of a first medical contact to device time of 120 minutes or less, it's a Class 1B recommendation that patient be transferred immediately. If we do not anticipate that we can make that deadline of 120 minutes, then at that point, if there's no contraindication of doing so, it's a Class 1B recommendation that would give fibrinolytic therapy or thrombolytic therapy in order to try to reperfuse the patient in a timely fashion. There are patients that are not very good candidates for reperfusion, and we'll go into that in a moment. As far as the thrombolytic agents that we use, most commonly today is TNKase. A few institutions are still using TPA. Streptokinase is not used very much in the United States at this point, but is used in other places. But there are patients in whom thrombolytic therapy poses an extremely high risk, those with active bleeding, those with intracranial bleeds, those who've had a recent ischemic stroke within the last 3 months, pregnant individuals, those who've had recent surgery or trauma, those with severe uncontrolled hypertension because there's a risk of bleeding in those patients as well, and those who've had to have traumatic CPR in order to keep them alive through the process will likely have internal chest damage that may be also a contraindication of thrombolytic therapy. Some cases, as I said, we'll find that there is anatomy that's not very suitable to percutaneous revascularization because of its complexity, and some of those patients may need to undergo bypass surgery, which of course would mean using a conduit taken usually from a vein from the leg, plugging one end into the aorta and the other end into the coronary artery beyond the area that's blocked in order to reestablish blood flow. But because of the time course that it takes in order to achieve bypass surgery, this is generally not a preferred method and is safe for those patients who cannot be mechanically reperfused or reperfused through thrombolytics. Now, what about patients who present with non-STEMI? They're a much more mixed bag, and so there has to be a lot of decision-making early on as to which patients can be treated medically and which patients should go to early coronary catheterization with an eye toward revascularization. And that involves risk stratification of the patient. So, for example, if we have a patient who arrives, they have a story of having had progressive exertional chest pain for a matter of a week or a month, and it's now progressed to the point that they have chest pain on very little exertion, and they've now developed even an episode of chest pain at rest, and maybe we're able to treat them in the emergency room and relieve their chest pain, but they have an elevated troponin level, and an EKG does not show ST segment elevations. We know that they've had a non-STEMI. That patient gives a good story for unstable angina, progressing to a non-STEMI. They likely have acute coronary syndrome, and that patient is going to be at an increased risk for further ischemia. And based on that, we may decide that we want to look early on in their course, within the first 24, 48, 72 hours, to do a cardiac catheterization to see if they have significant obstructive disease that might be benefited from reperfusion. On the other hand, if we have a patient who presents to the hospital and is in florid sepsis, they're hypotensive, they are unstable, they've never had any chest pain, they don't have any acute EKG changes, but they do have a mild elevation of their troponin. They've also had a STEMI, although it may be what we would consider a class 2 MI, not on the basis of ACS, but on the basis of extreme oxygen demand mismatch because of the stress of their sepsis. That patient may not be a candidate for an early invasive strategy. We may want to treat their underlying illness, in this case sepsis, and then consider later, once they're more stable, evaluating them further to see if they have underlying ischemia that would require further treatment. Most patients that we see with MIs should go home on dual antiplatelet therapy, which includes aspirin plus another antiplatelet agent, either clopidogrel, prasugrel, or ticagrelor. All patients who have stents are generally sent home on dual antiplatelet therapy. Current recommendations after an MI or unstable angina is that should be continued for 12 months. But current recommendations are also that in patients who have an acute MI and cannot be revascularized because of poor anatomy or because the vessels are not amenable to revascularization, that they should also be treated with dual antiplatelet therapy. What about other medications that we want to document in the record? A big one is beta blockers. Beta blockers have multiple actions in the body, but in the setting of an acute MI, their biggest actions are they decrease heart rate and contractility, and by decreasing both of those, they decrease myocardial oxygen demand. By doing that, we believe they can preserve myocardium. They also have effects on anti-ischemic events, antiarrhythmic events, and anti-inflammatory processes. So we can decrease the risk of ventricular tachycardia and ventricular fibrillation not only in the acute setting at the time of the MI, but also post-MI when the patient goes home, which is why most patients should be discharged on a beta blocker. Contraindications for beta blocker would be extremely low heart rate or hypotension or severe obstructive pulmonary disease, which worsens with beta blockers. Those patients may not be able to tolerate beta blockers, but other patients, when at all possible, should be discharged on beta blockers. Second class of agents we frequently ask about are ACE inhibitors. There's a molecule that's a precursor agent released by the liver called angiotensinogen. It's released into the body, and when the kidney senses decreased blood flow to the kidney, it, through the action of releasing renin, causes conversion of that to angiotensin 1. Angiotensin 1 itself is not a very active compound, but there's a second agent that's released primarily by the lungs and some by the kidneys, as well as some smaller amounts from peripheral tissue, called angiotensin-converting enzyme, which allows the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2 is an active molecule that works through many pathways, but as far as the heart is concerned, the biggest pathway is it causes some fluid retention and it causes vasoconstriction. And when it causes vasoconstriction, it increases blood pressure and it increases afterload so that the heart is having to work against a higher pressure. We want the heart to heal as well as we can after an MI, and so we want to reduce the workload of the heart as much as we can. So angiotensin converting enzyme inhibitors can help us by decreasing that afterload reduction and by improving cardiac performance. In patients who have impaired LV function post-MI, angiotensin converting enzyme inhibitors can also promote recovery of the myocardium over time by reducing that afterload. Similarly, we can also act at a different point in the pathway here by giving an angiotensin receptor blocker, an ARB, and ARBs will actually block the action of angiotensin II on the end organ receptors. And so there are a variety of flavors and types of angiotensin receptor blockers as well, and that's why we document them in the case report also. Now, many patients will go home on additional anticoagulation besides our dual antiplatelet therapy, not because of their MI, but because they may have other comorbid illnesses. So, for example, if a patient has atrial fibrillation, or if they've had a DVT in one of their lower extremities, or if they've had a previous pulmonary embolism, they may be on warfarin, and that needs to be documented because that patient may be going home on 3 different types of anticoagulation: warfarin, aspirin, and another antiplatelet agent. Similarly, with the newer thrombin inhibitors and the 10A inhibitors as well, we want to document in the record that they're taking this additional anticoagulation because they are at some increased risk for bleeding by the combination of medications we send them home on. We also want to document whether patients are being discharged on statins. Statins, as you know, are being used to decrease cholesterol levels. They work by blocking within the hepatocyte the production of cholesterol. They work by blocking the action of a specific enzyme, HMO-CoA reductase. And so at this point, they will block their production of cholesterol and, more importantly, LDL or bad cholesterol. Newer class of agents that's now available, PCSK9 inhibitors, work through a totally different mechanism. They're used in patients who are statin intolerant or patients who are on statins and cannot achieve acceptable levels of LDL, which should be ideally less than 100 or in some cases less than 70. They work directly on a protein that can block the LDL receptor on hepatocytes. So normally in a hepatocyte, LDL will bind to receptors on the cell membrane of a hepatocyte. They'll be taken internally. The LDL will be taken into the liver and reprocessed, and the receptor will return to the surface so it can bind additional LDL. But there's a protein also produced by the liver called PCSK9, which can bind to the receptor. When it binds to the receptor and the LDL compound, then that is internalized, and the PCSK9 protein will give a signal to the hepatocyte to break down not only the LDL, but to break down the receptor as well. So receptors are not returned to the surface and are not available to take up more LDL. The purpose of these newer cholesterol medicines, PCSK9 inhibitors, is to block the action of that protein so that the LDL receptor can work normally and be returned to the surface to remove more LDL from the bloodstream. In 1912, James Herrick, who was a extremely good internal medicine doctor and a very good at describing illnesses, described 2 of his patients who died from an acute myocardial infarction. One of them went to autopsy and was found to have a thrombotic occlusion of his artery. And that was the first clinical data that we really had that an occluded coronary artery was the etiology for most myocardial infarctions. He recommended at the time putting patients to bed rest for days to weeks to months, and in-hospital mortality during that time was about 30%. It was not until the early 1960s that we began to form coronary care units, which allowed us to monitor patients for significant dysrhythmias and to treat them aggressively with CPR and with ACLS. And by doing that, we were able to decrease the in-hospital mortality after an MI in half to about 15%. It was not until the late 70s and early 80s that we were able to provide myocardial reperfusion for patients. And now in the myocardial reperfusion age, we've been able to cut that death rate again in half. So it's our hope, by more widespread use of medical guidelines, such as we've talked about today, we will be able to cut that through your efforts in half again in the future. At that point, I'm going to stop the formal talk and I'll entertain questions, and I would encourage you, if you have any questions, to please ask, because if you've got the question, chances are some of the other people attending may also have the questions, and I'll be happy to try to answer them as best I can. Thank you.
Yeah, so remember to press *6 if you want to come off mute, or type your question in the Q&A section of WebEx. Okay, so we do have a request to pull up the slide 35 again. She said she wants to look at it a little bit more. So
sure. Is this the right one?
Yes, I believe so. Again, just a reminder to press *6 if you want to come off mute. Marta, yes, you can screenshot this. We're also going to send out the slides within a week of today's call.
And again, I would encourage you to ask any questions. You know, I went to a talk last year in Chicago, and a physician got up at the end of the talk and said, I really, enjoyed your talk and the preparation you put into it, and I felt like I really understood what you were saying. And then you said something that made me totally not understand at all what you were saying, and I was afraid to ask because it would make you mad. It was kind of like a conversation with my spouse. So I would encourage you to ask any questions that you have, so that you can leave today with a firm understanding of what we talked about.
Hello, this is Angie Perot calling from Texas Health HEB in Bedford, Texas. Can you hear me?
Sure.
Great. I was wondering, because you are a medical doctor, how do I get buy-in from my cardiologists or even my hospitalists to look at the higher intensity statins? Do you have any suggestions for me?
Well, I think that they simply have to look at the guidelines. That's the best way to approach them, is to show them that these are what the guidelines recommend in the post-MI patient. A lot of us have been trained over the years that you want to use the lowest dose of a medication that you can to get a clinical effect, and there are a lot of people who still have that philosophy. But statins, we know predictably, are only going to reduce the LDL by a certain portion. And so if someone has an LDL of 110, then, yeah, I could say maybe a high-intensity statin is not necessarily going to be needed to control that patient. But if someone has an LDL of 150, then clearly we're not going to control them with a small dose of Mevacor. We're going to need something more potent to get them to goal. And so rather than stretching out over a period of months of trial of agents that are going to be ineffective, it makes a lot more sense to go with an agent that we know is going to give us a predictable result.
Okay,
so I would present to them the guidelines, and that's what the guidelines recommend.
I have in the past, and what I'm wondering is, so where would you said if it's like 150 and higher to go to the high statin. So where would I start? Like, as I peruse my patient's charts every day and I see the LDL's 120, is that where I want to start asking about a higher dose statin?
Are you talking about a post-MI patient now, or are you talking about just in general with a patient with coronary disease?
No, a post-MI patient.
Post-MI patient, I think that the guidelines would suggest that you're always going to be better using at least a medium, if not high-intensity statin, even at a level of 120. Because, again, these days we're looking at more trying to reach a goal of an LDL of around 70 rather than 100. And so to get an almost 50% reduction in LDL, you're not going to get there unless you use a high-dose statin, a high-intensity statin.
Okay, very good. Thank you so much.
You bet.
Okay, and we did have a question pop up. Can you review a bit more about bypass related to STEMI? What is your belief if a PT can be reperfused with primary PCI in under 120 minutes but over 90?
In terms of having them on pump and getting them refused, is that the question? In within 120 minutes?
Yes, under 120 but over 90.
Right. So I think that, again, if you can't make that 90-minute goal, you're still better off going directly to mechanical reperfusion if possible. But I will say that I work in an institution that does not have bypass on site. And so I can tell you that there's one patient in the last 3 years that I've stabilized and sent for bypass surgery to another institution once I made them non-ischemic. And it was simply because of their anatomy. They had a high-grade distal left main lesion that involved the origin of both the LAD and the left circumflex artery, and it was not a lesion that I felt comfortable treating in an institution without on-site backup. But I think in general, mechanical reperfusion in the cath lab is going to be superior at achieving your time goals, and I think that's still the preferred method.
Okay, Angie asked, will the recording of the webinar also be available with the slides? She felt it was an excellent overview and would like to share with staff. Angie, to answer your question, yes, we are going to send out the recording as well as the slides within 1 week of the call. Okay, is there any other questions? You can press *6 to come off mute.
Hello?
Yes.
Hi, sorry. I was clicking *7. So my question more was for the bypass of when deciding to go for primary PCI or giving tenecteplase. So that's a big discussion that we're having, that potentially our institutions could bypass a closer hospital to get to our institution, which is a primary PCI hospital and does have on-site surgery that we could do if we needed to for CABG or anything. But the discussion is a lot of our non-PCI centers are saying, well, we can get you to the PCI center and probably get bypass or get primary PCI in, let's say, 110 minutes, but so what's the point in stopping here? But then that first medical contact to device time for us ends up being 110 minutes, not 90 minutes.
Right.
See what I'm saying?
Right. And that puts you behind the 8 ball when you do that. I think that when you look at the guidelines, it really suggests that you want to make that 90-minute goal if possible. If you don't have to go to an intervening hospital, if you can't make that 90 minutes, then you're probably better off going to a non-PCI capable hospital under the current guidelines, and then being transferred. And that's generally what the guidelines would recommend at this point.
Okay.
We have been getting a lot of comments saying that this was one of the best presentations, super down to a level that all could understand. So that's great.
Well, I appreciate that, and I hope it wasn't too elementary for the veterans who've been doing this for a while, but I wanted to make it accessible to most of the people.